Okay, thank you everybody for spending your Saturday afternoon here, and thank you for having me. So of course I'll talk a bit about hip and knee replacement, which are the commonest orthopedic surgery actually that's done in developed cities around the world, because we have less trauma as become more developed as a country, as a city, but we do have better longevity and a more active population, and hence actually more and more people do actually have arthritis that affects the lower limb, which are weight-bearing joints, which are the hip as well as the knee joint. So of course, we talk a bit about like why do we want faster recovery, right? We talk about value-driven care, which is very in line with the Ministry of Health, Singapore, the guideline. So what is value truly? Value is actually the health outcome that matters to our patient, divided by the cost of delivering this outcome. So if we can improve the health outcome and or we can reduce the cost of delivering this outcome, we actually can give our patients better value. And this is actually the new blueprint for our Ministry of Health in Singapore. And so then next question we ask, what's ERAS, right? ERAS is actually a short form for Enhanced Recovery After Surgery. What it entails is that reducing the length of stay, from the usual, like for example, 4-day average after lower limb replacement surgery, to that of less than 23 hours, less than 18 hours. And in the longer term, we want our patient to recover faster so they can return to their games, like whether it's table tennis or traveling, hiking to Jade Mountain in Taiwan or other places, or even in Europe doing pilgrimage trips. So these are all activities that can be restored to our patients who suffer from hip and knee arthritis. So what truly is ERAS? Essentially, it's a combination of improved surgical technique and better anesthesia care, as well as physiotherapy, enhanced physiotherapy, thereby providing our patient with a faster and more effective recovery process after surgery. So I'll talk a bit about hip replacement first, then we go more in depth into the knee replacement. So hip replacement, one of the things that we read very often in recent years is the direct anterior approach to the hip replacement. If you read the Straits Times, the SGH Changi Hospital, both have report about this, about their own individual experience, right? So what really is this direct anterior approach, hip replacement? Essentially for patients or for people with end-stage arthritis of the hip, with severe hip pain limiting their function, like they cannot walk to the holiday like before, they're always the last in the tour group, they cannot keep up with their family outings, and hip replacement is actually a good option for the middle age to the elderly. And what is direct anterior approach? Essentially it means the surgery is done from the front, which the scar is at the front, rather than at the back. Traditionally, about 10, 15 years ago, everyone who undergo hip replacement in this country had the surgery done from the back. So the scar is at the back, the buttock area. But in recent years, in recent 5 years, we have improved our surgical technique, very much in line with North America, some parts of Europe, Japan, Korea, as well as Australia. And if we see our medical literature, we will see that the uptake of direct anterior approach total hip replacement has increased over the years. And why is this the case? Because essentially this is a muscle-sparing approach that results in no cutting of muscle during the surgery, and thereby resulting in less pain after the surgery, shorter hospital stay, and medical evidence have shown faster recovery within the first 6 weeks. So it's a study by Mayo Clinic, one of the biggest centers in the United States. They actually took a look at this, what we call the direct anterior approach, or DAA in short, versus a posterior approach, which is the traditional. Posterior is where the scar is at the back, where we split the muscle. That was done like for the last 10 or 15 years ago. So in their results published in 2018 from Mayo Clinic, you can see essentially those people who undergo a direct anterior approach hip replacement required less time to discontinue walker use, less time to discontinue, in fact, all gait aids, including walking stick, quad stick, as well as walker frame. And in their study, if we look at the mean, the average number of steps taken per day at 2 weeks after surgery, right? Is for the direct anterior approach is 3,897 versus 2,235 in the posterior, the traditional O approach, right? So what it means essentially, in summary, is that from their study, actually the recovery is much better in our muscle sparing approach, and I think this should be the standard of care, in my opinion, for anyone who undergo hip replacement. Of course, what does 3,897 step means, right, in a local setting? So I see hip and knee pain patient almost every day at work. What usually for 60 plus middle-aged lady, if you can do about 7,000 steps to 9,000 steps, you're actually doing quite well, quite good. After dinner, like, you can continuously walk. You can check the steps. So average Singaporean is about 7,000 to 8,000. They're about for 60 plus. So if 3,800, we are actually almost there, but not quite there yet. But this is only 2 weeks after surgery. Most of the time, with hip replacement, by 4 to 6 weeks, you should be able to achieve that level, which is quite what we call the mean, the average for our local population in our local setting. So of course, the other advantage of this direct anterior approach, which you probably read in the newspapers in recent years, the lower risk of dislocation. Dislocation is when sometimes the hip joint drop out, right, after artificial hip replacement. With modern techniques, this risk is actually very low. It's about 1% or less. With the direct anterior approach, this is actually even lower than 1%. Yep. So it allows us to do positions that we used to not be able to do at the start. So in the old time, maybe I show you in the posterior approach, we do not, after surgery, we do not want the leg to be internally rotated, and we do not want to bend such that it can pop out backwards, right? Bend out and pop out backwards. So we try not to do this action where we look at the outer part of our calf. But with the direct anterior approach, this can be done. So patient can actually squat, can do squatting, and they do not have to do hip precaution for 3 months after surgery. It's also good not just for the elderly, for the middle age sometimes because of steroid use. Some people do have to undergo hip replacement surgery earlier because of, for example, steroid use or previous trauma to the hip, right? So then, because of hip pain and stiffness, sometimes people also sometimes ask me more sensitive questions like, when can the couple get back to their activity, right, together after hip replacement? So usually with better techniques, usually by 3 weeks out from surgery, most couples can continue, start off their usual activities. And by 8 weeks, usually the satisfaction is usually very good. This is based on, of course, American studies. We do not have any local data yet on this, but I think it's reflective also when we speak to our patient in the clinic. Okay, so of course with less pain technique, right, you can see we can actually do 2 hips at one time. 2 hips at one time instead of the usual where we do 1 at a time. So for people who have both hip disease, actually this is an option, and we've done quite a number of surgeries. In one anesthesia setting, we actually replace both hips. I give some example, probably easier to visualize for us. You can see, so this is a man on the day of surgery. One side hip replaced, is walking without any walking aid. And this is the same. For the ladies, it can be done as well, right? One side hip replacement. Of course, you can see she's on the skinnier side, probably a bit less muscle mass than our gentleman, but it can be done as well. So the immediate pain relief after the hip replacement is actually very, very significant. So most patients are actually very satisfied after the hip replacement. In terms of full recovery, we can say usually at 2 weeks, some people wean off walking aid, some do not. By 1 month, most people are walking without walking aid. So what's new then? The direct anterior approach is a new technique, in the last 5 years for hip replacement. For the younger population or the people who are more scar sensitive, right, in terms of scarring, we can do it over a bikini incision. So usually, you see the lower picture, usually the scar will be longitudinal. In this case, we go down the front of the hip. For people who are younger or more prefer a nicer scar, sometimes we can do a transverse scar, which is in line with the skin crease actually, and usually can be well hidden by the undergarment or swimwear. Yep. And the other thing I think in the hip replacement that is more advanced is, of course, robotic surgery, like urology, like ONG, like many other specialty in medicine. We have to embrace technology and decide whether how much help it is for us to provide good outcome. And what does robotic surgery in orthopedic actually means, right? In the hip replacement, for example, we do a CT scan before the surgery that allows us to understand better than X-ray our patient's anatomy of the hip, the problem, as well as their native, how they are born with native anatomy. And you can see actually in the video, we can actually plan the positions of our implant before the surgery even, right? Looking at all 360 degree. And if we do see any redness, just on the redness, i.e. means that potential impingement, we can change the way we want to position our implant, the alignment, in terms of what we call the anteversion, as well as the abduction angle. So it allows us to actually plan the surgery before even our patients go under anesthesia. And what it confers is a very reproducible outcome in terms of implant placement, specific to individual needs of our individual patient. In the old time, before robotic surgery, usually what we do is, if it was the back approach, usually we open up the hip joint and then we place it as best as possible based on what we see on the table, right? But then we test for impingement, change the placement of the implant if required to get stability and to get length. But now with modern technology, we do X-ray during surgery, or we do robotic surgery that allows us to pre-plan the perfect alignment and placement of implant for our patients before we will execute it. And during the surgery, all we need to do is to execute our plan very predictably. Now this is an example. You can see one of the high-riding hips with shortening. Actually, the leg, you can see, is 41 mm, i.e. 4 cm shorter on the left side. And with the robotic surgery, we can actually plan to be just 6 mm shorter. So we usually want to lengthen no more than 3 to 4 cm, because if not, there'll be nerve injury for patients with very bad shortening of the leg. So in this surgery, for example, we managed to achieve good leg length, actually, and it allows very predictable surgery, once again, with robotic technology. Of course, now we are able to handle more complex surgery as well. You can see all these examples of like very bad hip arthritis wear and tear, where the hip joints are subluxed or dislocated out of the original socket. For example, in this case, the left side. And after the surgery, we can actually restore it very nicely to be very similar to the other side, the right side. Yep. Hip replacement is a very interesting thing, because today we hear about cardiology, right, and urology, eye, and orthopedic. So the number one surgery in medicine, right, in terms of patient satisfaction, is actually total hip replacement. Number 2 is cataract, and number 3 is actually total knee replacement, of which everyone heard about it. We'll hear everything about it today, right? So we call it the surgery of the century, because you will see that there are people who can do ultra marathon even if in the younger population they get hip problem. We fix it for them. I think it's also in Straits Times, there's someone who actually could do a marathon after hip replacement, and these are all possible. And sometimes we get people with very high BMI, closing in on 50, 40 plus, almost 50 BMI. And again, you see with the better surgical technique, we use an X-ray during surgery, we can actually very well place the implant, which is actually on the lower right-hand corner on the screen. Yep. So in summary, for the hip, what can we expect from an ERAS, right? Enhanced recovery after surgery. We can expect to have faster recovery for this ERAS technique, especially in the first 6 weeks for the patient. Right, they are expected to walk on the day of surgery. So if surgery is in the morning, in the evening we'll be walking. If surgery is the evening, the next morning we'll be walking. Yep. And of course, if for people who wants to stay in hospital, a couple of days, that's definitely okay. For people who want to go home, right, within 18 hours or 23 hours, there's also an option to rest at their house, because for some, resting at home is actually more comfortable. And so far, we have over 500 patients who actually benefited from this program. And cost-wise, it's definitely more affordable. Yep, so that's a hip replacement, one of the best surgery actually in medicine. And we go on to talk a bit about knee surgery, knee health. Okay, so for why is knee important, right? So in a local setting, to be more relevant, actually knee pain is most common bone and joint complaint, right? It's very common, like back pain, knee pain is very common. Actually, more common than hip pain, in fact, or shoulder pain. And with an increasingly aging population in a developed country like Singapore, where there's a lot of focus on healthier SG, healthy living, people are more and more active, people travel more around the world, especially during retirement. We actually what we want as a country is to be active and healthy, right? To live a purposeful life, even whether it's before or after retirement. And therefore, it also translates to higher expectation for treatment after knee pain. In the past, when we can say, for example, 15 years ago, I would say someone with end-stage bone disease, right? They say, oh, knee replacement, no, they're pain-free, can walk to the market, they are happy. But now, what our patients want and what we want is that, they can go traveling, they can continue playing their table tennis in the community club, they can go out, take care of their grandchildren, they can do things that are much more similar to what they could have done like 10 years ago when they were younger. And so we have people who say, they want to go back to jogging, they want to go back to golf, they want to go back to tennis, badminton, so and so forth, actually. And that's why I think knee health has become more important. In the old time, we say, after knee replacement, you don't walk so much, you worry about the implant wear out, right? Now we have people who run marathon, like this patient who emailed me. So he actually did a partial knee replacement, and he ran a full marathon for 2 years, right? In 42 kilometers. I can't run 42 kilometers, so he's actually even better than me. Yep. And I think that's what we will be expecting as we progress as a developed city, to actually bring people back to their pre-arthritic, pre-pain lifestyle. And what's the prevalence? So very interestingly, actually year on year, based on ministry data, the prevalence of knee replacement is actually increasing. And with recent years, it stables around 4,000 to 5,000 a year, actually. So that's actually quite a lot. And for partial knee replacement, it's about 20% of the total knee replacement volume, which is about 1,000. So I'll talk a bit about osteoarthritis, which is the most common cause of knee pain, actually, in our local population. Non-traumatic knee pain. So traumatic, usually the younger people, they get anterior cruciate ligament tear, meniscus tear. Meniscus tear, for example, can be treated non-surgically or surgically, depending on the tear configuration, whether it's stable and how active or how symptomatic is our patient. For osteoarthritis, most of the time it's a gradual worsening thing. So what happens is that usually it happens in a normal knee, like normal anatomy, that experience abnormal load, i.e. heavier body weight, or abnormal knee, which is a previous trauma, previous fracture of the knee joint, broken meniscus that's not repaired, for example, or people with rheumatoid arthritis, gout, where it's abnormal, the knee joint is abnormal, experiencing normal load. So what are some of the risk factors? Advancing age, right? As we get older, sometimes the meniscus, the cartilage not as good, and we get this arthritis, primary osteoarthritis. More common in the female. Female to male ratio is about 7 to 3, 70% to 30% in our local setting. Genetic predisposition. So genetic predisposition is very interesting. It's a polygenic kind of inheritance. So there's no one gene that causes it that we can do gene therapy for. Rather, it's more like if like my sister, my mother have it, my sisters have it, I'm at actually higher risk of having it. Yeah, so it's more like a polygenic kind of inheritance pattern. And of course, other risk factors are like previous trauma and rheumatoid arthritis and gout, as we have mentioned. And how we decide how severe or how serious is it, right? So it's grade 0, grade 1, grade 2, grade 3, grade 4, right? So the cutoff is at grade 2 and 3, not in between. So usually 0, 1, 2, is where we say, we can try some physiotherapy, exercises, take some supplement. So supplement like turmeric is very good, reduce inflammation for the knee joint. Collagen-based supplement like UC2, which is undenatured collagen 2, are very good also. Glucosamine, a lot of people know, right? A lot of people probably have tried along the way in their lifetime. What I hear from my patients is that it's 50-50, or probably even less than 50. So some say glucosamine no use, is waste of time and that type of thing. I think turmeric has a higher proportion of people saying it's useful to reduce inflammation for the knee. Also collagen-based product like UC2. So, of course, that said, although more people say turmeric seems more useful than glucosamine, I also have patients who tried turmeric and say it's useless, and glucosamine seems to help to relieve the pain and inflammation. So, if we are at grade 0, grade 1, grade 2, I think these are the modalities we can try. Basically, physiotherapy, strengthen the quadricep muscle, strengthen the hamstring muscle, i.e. the muscles around the knee joint. Do things like cycling, even stationary cycling is very good. Swimming, which are low-impact exercises to strengthen the muscle, and take some supplement, and as per required, we take some painkiller when required. So these are very good treatment modalities for grade 0, grade 1, grade 2, right? When we reach grade 3 or 4, that's where the challenge comes in. Usually once there's significant joint space narrowing on the X-ray, I had to say bone spurs are there, the joint space is narrowed. Invariantly, sometimes many people will have two outcomes usually. Once it's like grade 4, for example, right? They either accept a lower function. That means in the past they can walk 1 hour, now they can walk 15-20 minutes, and they accept it before they rest, right? Or number 2, they actually go for joint replacement surgery, and they get much increased, better functional benefit. So grade 4 is the tough part. Sometimes the challenge is always the classical history, right, of our arthritic pain, on and off pain, on and off. That means if I walk more, I exercise more, I go for a longer holiday, the pain come on, right? If I stay at home, watch TV only, there's no pain because I don't weight bear. So it's always to people, it's always a dilemma, right? Sometimes I have pain, then I want to do something more to treat it. Then when I want to do it already, there's no more pain, right? So it's like this pain, no pain, pain, no pain kind of thing. I think what we can do is we monitor. That means if the pain frequency get more and more frequent, right? That means the arthritis is getting worse, not as good. If the pain, number 2, if the pain intensity is getting more and more intense, that's also a sign that the knee is not coping as well. So these are the actually more important things we can actually try to monitor and look at, rather than the single episode of sudden pain. What some people say is troublesome or irritating for them is that, say they plan a holiday, right, months ahead, and just before the holiday, there's sudden onset of acute knee arthritic flare pain that actually limits their function. So when all in all, if you reach grade 3 and grade 4, sometimes if the pain is bothersome and reduce your function, that means things you want to do or you used to be able to do, you can't do anymore, then probably a knee replacement is a very, very good option. Of course, arthritis of the knee also can affect one compartment. So the knee has 3 compartments, 3 areas, 3 zones, right? The inside of the knee is called the medial, the outside is called the lateral, and the front, just behind the kneecap, we call it PF, or patellofemoral, right? So whether it affects one compartment or all 3 compartments actually affects our surgical treatment. So one more thing we did during COVID, you can see we actually followed up 160 patients, during COVID, where we closed no elective surgery as per ministry guideline, and see whether they deteriorate, right, because of knee pain, and whether their function deteriorate. So we look at things like Knee Society score, American Knee Society score, Oxford Knee score, which is from UK, and things like short form 36, which are like actually our quality of life measure. And actually, ironically, we found that people who have knee pain and could not undergo surgery 6 months later, right, because of COVID, where we closed all elective surgery, and we actually, or everyone hands on deck for COVID management that time. We found that most people deteriorate actually, because as we postpone the surgery. So in essence, I think timely surgery when required is actually quite important, and will actually confer very good outcome. Of course, for middle age, when we're younger, we try to do keyhole, right? Keyhole to preserve as much as possible, fill up the defect, the cartilage defect. When we reach a certain age, then what we want is that if there's pain bothering your function, X-ray shows end-stage arthritis, right? Pain affecting your function, number one. Number two, X-ray show end-stage arthritis. Then if we want to consider a surgical option, we want to do one surgery that can last 95% or higher chance, last you a lifetime, right? We don't want to do one, then later few years do one more and do one more. That's no good. So we just want to do one time, right? If we want to do it, and have the best chance to last the whole lifetime. And this, if it's a single compartment, i.e. one area of the knee joint affected, usually we suggest a partial knee replacement or partial knee resurfacing. It's a small scar, faster recovery. We walk on the same day. Most people can go back to jogging or hiking, or some even run marathon. For those who have all around the knee joint that are degenerative, then we suggest a full knee replacement. So again, in the knee joint, just like the hip, it confers a shorter length of stay, and we want to minimize perioperative complications. So actually we have a very good workflow so that most of the patient can stay shorter and yet at the same time achieve just as good or even better outcome. And we look at some of the reasons why patients used to stay very long 10 years ago, right? Number one is definitely pain. So this same surgery done 20 years ago, standard of care is patients after surgery on morphine, IV morphine, right? Or patient-controlled analgesia. So almost invariably, even as close as 10 to 15 years ago, right? Most patients need morphine after this surgery, right? Because of pain. In recent time, in the recent years, I think morphine is not indicated. Yeah. So I would say like 99% of the people who undergo this surgery now do not require intravenous morphine as after post-operative analgesia, because that's a thing of the past, an outdated kind of the technique. Of course, why is it better? We can do less soft tissue dissection, i.e. the surgery is done more straight to the point, right? And including things like kinematic alignment technique. What we also do is sometimes we give a nerve block to actually relieve the pain post-op and reduce opioid use after surgery. And of course, third point is perioperative analgesia. So we use multimodular pain like other class, like say Panadol, NSAIDs, which are non-steroidal anti-inflammatory drug. Yeah, and sometimes lighter opioid, like say Tramadol, rather than morphine. Yep. So this is our nerve block, how we do it. You can see the incision usually for knee replacements is about 4-5 finger breadth, right? For partial knee, it's even smaller, and this is how we give the nerve block. And other reasons, right, why people used to stay 4 days, or there is a transfusion. So 10 to 15 years ago, again, we talked a bit about last time, right? Transfusion rate in a general hospital ranged between 6 to 12% after the surgery for knee replacement. Now our standard of care is almost zero. Okay, again, in medicine, we can't say zero, so we usually study as 1% or less, right, for transfusion. I think it entails a few things. First is better surgical technique, better surgical dissection. Number two is the use of adjunct medicine like tranexamic acid, which is also used in like menorrhagia and, for example, that actually help reduce blood loss. And number three, we have better screening. We screen for preoperative, the hemoglobin, the red cell count, make sure that if it's low, we treat it before we do any elective surgical procedure. And of course, one other thing is common last time is post-operative nausea, vomiting, right, from the anesthesia. And this we have also eliminated very well with just enough anesthesia. Right? Not too much or not too little. So our anesthetics also become better, actually. They give it just enough for the surgery. So you don't have like those after the surgery is completed and 3-4 hours still down there vomiting because of too much anesthesia, kind of thing. And we also have antiemetic medicine to reduce the need, or rather the sensation of nausea and vomiting. So again, after all the words, right, we're going to see some big video of what is this. So partially, what to expect, for example, this one was the day surgery. So usually what happens, day surgery do in the morning, and then the patient will be walking at 4 to 6 hours after that. You can see he's changed out to his home clothes, the dressing is still on, right, ready to go home. And at 2 weeks, usually they can, especially for gentlemen who have more, quite good muscle mass like him, he actually drove to the clinic for his follow-up, and his surgery was on the right knee, as you can see. So even medical evidence from United States will say driving is very safe after 9 weeks from knee replacement. I think in our local population, whether it's partial knee, maybe can 2 weeks like what he did. Full knee replacement, some people can even do at 2 to 4 weeks for driving of automatic car. That means not the, the manual, like my license is manual, right? So I had to clutch in on the left, but I'll drive an automatic car now also. So all I need is my right leg. So this, of course, this gentleman underwent a right knee surgery. So another one, even younger, this very young, 51, you can see. Why he needs surgery younger is because when he was younger, he has a trauma, a fracture. So you can see the picture actually on the right-hand side, you can see the tibial bone, which is this bone, there's a crack, and it's a very weird shape, it's like a bowl shape, right, because of trauma, and it causes a malalignment of the lower limb, and therefore faster arthritis. So you can see he needs 10, 12 hours at work, and his livelihood. He actually have to stand and does his work, right, which he enjoy and which he requires to maintain his living standards. As you can see, this is what happened. He's walking very well after surgery. Can do a reverse walk as well. Moving on to full knee replacement, right? So for people with more advanced condition or disease in the knee joint. So with our enhanced recovery ERAS pathway, over 2,000 people have actually undergone this and discharged within 18 to 23 hours after surgery. Some people in the old time, you always say, the implants in Singapore are from United States, right? So we cannot do deep squat, we cannot do our Buddhist or Muslim prayers, that type of thing. But I think in a certain group, actually can be done, like for example, for this patient, this standard prayer position for her, for her religion, and we can actually reproduce it for her after a full knee replacement. Yeah. So how about the slightly older, 77, closing octogenarian, right? Can they actually manage it, right? For a healthy 77 years old, like I, generally quite healthy, maybe so you only got like sign gout, right? Hypertension, high cholesterol, and diabetes, for example. You see, they can actually, he, for example, he did the surgery 3 months apart, one knee and then the other knee. And in the morning, and of course you can see he's walking with a walking frame. Yeah, he also chose to go home, actually, as a day surgery. Of course, he does not walk as well as the 50 plus years old, right? But I think for 77, it's very, very commendable, actually, for his walking and his recovery. So essentially what knee replacement does is, number one, relieve pain. Number two, we correct a bend, a bow leg. Whether it's a bow leg, which is this way, bow like O-shaped leg, or a lock knee is this way, right? We correct it to straight. So you can see after surgery, the knee should be straight. Center of hip to center of knee to center of ankle. Yep. So again, we have to talk about robots, right? Because something that at least in the orthopedic bone and joint field is something more relevant in the recent time, you can see. So again, like the hip replacement, you see in the knee replacement, we can actually have photos, what size of implant to use, how we're going to balance the soft tissue, the tension of the ligaments in the knee to restore function. And all these are planned before surgery, and all we need to do is to execute it. Yep. So in summary, I think ERAS is a safe and cost-effective measure for joint replacement that can benefit everybody. And I think with more people understanding what it entails, actually, more people can actually benefit from it. And with that, thank you for your attention, and again for coming on a Saturday afternoon.
All right, thank you, Dr. Chen.
Thank you.